to questions which have been raised by the call participants. Inevitably, there will be a bit of dancing around between topics here, and I will try my best to guide us through it and to put them in some order, but please bear with me on this. Could I begin by asking some questions on the theme of unnecessary blood transfusions and the role of tranexamic acid, which the inquiry has heard something about. Professor Bellamy, if I could begin with you. You said earlier that Schott was interested in trying to bust some of the mythology around the decision-making to give a transfusion in the first place. Could you give us an overview of what that mythology is that requires busting?
Yes. Bit of a hobby horse, I'm afraid, so I will try and be concise, but I may fail in that endeavour. Right, first of all, as regards transfusion of red cells, in my own area of clinical practice in intensive care, there's pretty good evidence that apart from in certain patient groups like cardiac surgery and so on, it's better not to transfuse to normal blood count values, but to adopt a lower target, a restrictive transfusion threshold. So if a normal blood count was, say, 113 grams per litre, then you shouldn't be transfusing to 113 grams per litre, because people do just as well if you keep them in the 70 to 90 bracket without having the complications of that additional transfusion. Getting that message out to other teams around the hospital, other clinicians outside of critical care, can be very difficult. So you'll have Dr. X will wander in to see his patient who's been admitted to critical care and sneakily prescribe 2 units of blood to bring them back up to 113. Completely unnecessarily, but he thinks he's doing the right thing because he's correcting the numbers, not based necessarily on evidence. So that would be red cells. Another major area, and this is an even bigger one, is around using fresh frozen plasma or platelets to correct clotting. Now, in a number of situations, the clotting numbers on a blood test may be abnormal, but that doesn't mean that the patient needs to have those numbers corrected. If they're not bleeding, if they're not at risk of a big spontaneous hemorrhage, they don't need their numbers correcting. And there's a bit of a disconnect in any case between the numbers on clotting tests and the actual increase in bleeding. If you do functional tests, you often find that you can have quite abnormal numbers, but functionally your clotting's not far off what it should be. This becomes important where there is an insistence on correcting clotting numbers, often with large volumes of fresh frozen plasma, prior to a relatively minor procedure where the risk of bleeding, even if it occurred, could be sorted out by putting a stitch in, pressing on it for 5 minutes and walking away. So a disproportionate reliance on correcting the numbers with clotting products. And this leads to large quantities of fresh frozen plasma being prescribed each year unnecessarily and administered. It's proving a very difficult myth to bust despite the evidence base. And of course, large volumes of fresh frozen plasma are not benign. Quite a few of our cases of transfusion-associated circulatory overload are associated with fresh frozen plasma. Quite a lot of other adverse reactions are associated with that. Similar arguments apply to platelets. Your clotting has to be really pretty. The evidence would suggest don't give these products and correct the clotting if they're not bleeding and if it's a relatively minor bedside procedure. If they are bleeding, then all bets are off. That's different. But if they're not bleeding, what are you trying to achieve? If you do your procedure and they do then bleed, then it's maybe reasonable, if you can't control it by other means, to give a blood product. But again, what evidence there is would suggest that the rate of significant bleeds is the same whether you pre-correct prophylactically or you don't. Therefore, I would suggest you don't. You also asked about tranexamic acid. Again, this, I suppose 10 years ago, nobody was doing it, and it is gradually creeping into clinical practice, largely as a result of the Crash 1 and Crash 2 studies and the excellent work done by Professor Beverly Hunt at King's, who have convincingly demonstrated the reduction in transfusion requirement in major blood loss where tranexamic acid is administered. And the adverse reactions to tranexamic acid are pretty uncommon. So its risk profile is a lot lower than the transfusion it's hoping to prevent. Very simple to do, very easy to do, very cheap to do. It's in every cupboard, in every operating theatre up and down the land. So really, there's not, unless somebody has a known intolerance or allergy to it, there's not a lot of reason for not doing it. So, okay, that's a kind of a clinical perspective. They are slightly hobby horses of mine, and I'm not trying to sort of give you all a lecture about clotting technology, but there are myths out there which suggest we should be giving blood products, and it's nonsense. So, a lot of cultural change needed there, and part of the problem, of course, is that each new generation of doctors who come through seem to believe the same misconceptions that the last lot believed that you've just about beaten out of them. So it's a problem. It's my hobby horse.
You've addressed it partly there, but why is it that this tanker is taking such a long time to turn around?
I don't really know. If I knew, it would be a lot easier, I think, but I don't really know. But there is a culture in medicine of beliefs handed down from generation to generation to generation, and I do it because that's how I was taught to do it, without ever looking at things critically. And just occasionally you get a really big, well-publicized, incontrovertible study that comes through, like Beverly Hunt's work on tranexamic acid, which does act as a light bulb moment, and we need more light bulb moments.
One of the questions that I've been asked about tranexamic acid is there a role for SHOT to play in promoting the greater use of tranexamic acid, or the greater option of use of tranexamic acid?
Potentially, yes, insofar as SHOT produces educational material. And if you look at our website, there's a huge amount of educational material, including sort of videos and training packages and so on. And the natural place for tranexamic acid would be in that body of educational material. It doesn't fall into our SHOT reports and such like, because it's not something that gets reported to us. For example, somebody may have a major hemorrhage. If there's a delay to obtaining blood products or a transfusion reaction, that would be reported. The fact somebody didn't give tranexamic acid wouldn't be reported.
That ties in with a wider question that I've been asked to put to you, which is who is responsible for reporting a blood transfusion that was given unnecessarily, and tied to that, the fact that tranexamic acid wasn't given, meaning that the blood transfusion either had to be given or was larger than would otherwise have been the case?
I suspect that most blood transfusions given unnecessarily do not get reported. I'm pretty certain of it, except where TACO, transfusion-associated circulatory overload, ensues. I'm pretty certain of that. And so that's not answering your question. Your question was who is responsible for reporting it, and the answer is, in practice, it doesn't get reported very often. In my ideal, I'm going to avoid your question again. In my ideal world, the person that we would like to see in trusts in the future, perhaps linked to the PSERF programme, perhaps linked to the transfusion programme, but who has the overall oversight and responsibility for reporting to SABR, would hold the ultimate accountability within that trust for that. Of course, in order for them to be able to do it, they would need to know about it, and for them to know about it, we need better transfusion records in hospitals, which include what the haemoglobin was before, what the haemoglobin was afterwards, what was the rationale for giving this transfusion. There are exceptions to the rules, but there are a lot more occasions when the mythology supersedes the rationale.
Would it be helpful for such a record to also contain a box saying, was tranexamic acid considered or offered?
I think it would. Particularly, the situation where tranexamic acid is likely to be of value is in the fairly brisk major hemorrhage, for example, in the operating theatre. But it could be part of the debrief, if you like, after a major hemorrhage in an operating theatre. When the major hemorrhage is recorded, part of that debrief could include the question, was tranexamic acid administered? If not, was this an oversight, or was there a specific rationale?
Of course, in order to make a report about an unnecessary transfusion, it has to be recognised that the transfusion was unnecessary. Does that come back to the previous point about myth busting and a realisation that you don't always have to give as much as people might?
Yeah, so the two prongs to that are partly about the myth busting, but partly also about better record keeping and documentation, so that the reason for the transfusion is documented. Some hospital record systems, some LIMS systems allow you to do this, and others don't. So we need more consistency and uniformity, so that there is always a reason why the transfusion is being prescribed. The expected starting and finishing blood count values, if it's red cells, and a defined finishing point. If it's fresh frozen plasma, what is the defined endpoint? And correcting the INR, correcting the clotting number, I don't think should be accepted as a defined endpoint unless there's active bleeding.
Would you expect, if that sort of documentation was put in place, would you expect the unnecessary transfusions to be picked up on an audit?
I would expect them to be picked up on an audit, but I would also expect it to change people's practice.
If an unnecessary blood transfusion is identified, would you expect that the recipient is informed and that the donor is informed?
That's a good one, informing the donor as well. I can see that there is a moral obligation to do that. Currently, obviously, there is no mechanism for doing it. Should the recipient be informed? Yes, but at the moment, we are so poor at even informing recipients that they've had a transfusion at all, that explaining to them the rationale behind it and whether or not it was strictly necessary is I think still beyond us until we have addressed this whole question of record keeping. I think at that point it's entirely reasonable for any recipient of a transfusion not only to know that they have received a transfusion, but the other bits of the document. What was the reason it was administered? What were the starting and finishing values? Why was that dose chosen of whatever blood product it was? I don't think that's impossible to do with better practices and IT. I think it's an achievable goal. Not everyone, of course, will wish to know, but the information should be available should they wish to know.
Professor Newberger, can I ask if you have any additional comments on that line of questioning?
Just a couple of minor points. I mean, I agree the best way to safeguard people from the adverse effects of blood is not to give it, if the risks are obviously the benefits. there are good guidelines from NICE, there are good guidelines from NHSBT about the use of tranexamic acid, and it's only ignorance, I think, that prevents people from doing it. The other thing is to go back to another recurring theme, is certainly in our hospital we have very good IT. It's all integrated, it was bottom up, but there's electronic prescribing. And so, for example, for medication, it will relate and say, you're giving this diuretic, but the patient's potassium is low, do you really want to give it? And there's no reason why you shouldn't do the same for blood, saying the patient's hemoglobin is 105, why are you prescribing hemoglobin? So you could very easily build in, and again, the clinician has the opportunity to override it. They have to enter their password to, if you like, show that it reinforces to them that their name's on the risk. It may well be indicated, but they have to justify it. So that's another way of building in, if you like. And the same in my field of liver disease, we've done exactly what Professor Bellamy said about where I chaired the group looking at indications for liver biopsy, making the point that often platelet transfusions, fresh ozoid plasma to correct clotting defects, are not indicated. And you could build this form of education and control in. It wouldn't override clinical judgment, but it would alert people, and certainly from the drug prescribing point of view, it leads to far better and, most importantly, safer prescribing. So I think there are technologies that could be used and ideally will be used.
For the sake of a transcript, I should note here that Professor Bellamy was indicating his agreement with you as you spoke about those electronic control mechanisms. Dr. Cave, could I ask for your thoughts on that line of questioning?
Yes, I haven't really researched tranexamic acid. I think Dame June Rain commented on it in her statement. Other than to say, I'm not sure it's licensed for surgical procedures, for blood loss in surgical procedures, but that's always obviously a clinical decision. I suppose in terms of, it comes back to the risk-benefit equation. If there is no benefit, then any risk from the procedure is too great. So obviously unnecessary transfusions, while outside of the MHRA remit, in terms of the benefit-risk equation, I could only agree.
Thank you, and you're quite right. Dame June Rain did speak about this on Monday, and that is on the transcript as well. Professor Bellamy, I've been asked by several core participants if you could explain a little more about how it was that SHOT came to be set up and what was there or was not there when it was established in the years 1994 to 1996. Yes,
there were. It's more the question of what was not there. So it's kind of like Genesis, and in the there's this great void. Not quite, because there were hospital transfusion committees, there were regional transfusion committees, and a national transfusion committee. The Royal Colleges existed, particularly the Royal College of Pathologists. So there was some oversight of transfusion, but there wasn't a system for systematically collecting data, collecting reports of events, and compiling that in a systematic way and analysing it in a systematic way. And the individuals who were involved with setting up SHOT, whom I think have, many of whom have spoken to this inquiry at an earlier stage, Dr. Lorna Williamson, for example, was involved with that process and wrote the editorial in the BMJ when SHOT started. SHOT, there was 2 years of committee work, consultation with user groups and professions to try and work out how this should be done, what it should look like, and what sort of data should be collected. The main driver at that time was, as you'll see if you look at our very first SHOT report 25 years ago, the main driver was the big problem of transfusion reactions and incompatible transfusions, and this was all around patient identification, the wrong blood for whatever reason finding its way into somebody despite notionally checks being in place. So that's where it started, and the number of reports was very small at that stage. And over the next few years, and if you kind of plot how the reports develop, it very rapidly expands, certainly in terms of the number of categories of transfusion error and incident that we look at. I was involved with a hospital transfusion committee at that stage, but not with SHOT. I wasn't involved with SHOT until the next decade. But I was involved with the transfusion committee and the regional transfusion committee at the same time as it was sort of coming into being.
Thank you very much for that. If I could ask you and then perhaps the rest of the panel, a suggestion that's been made is that it might improve the reporting of near misses and other reports, and indeed the documentation of transfusion, if a learning resource about the infected blood scandal was developed and made mandatory for training purposes. Is that something that you consider would be helpful?
I think it would be. I think, as it is, the infected blood inquiry and its outputs have had a lot of media attention. It's highly topical. And I think because of that, it would not be difficult to create training materials that would be rapidly adopted. And I'm pretty sure there would be an appetite for that.
Professor Newberger, if I could turn to you on that.
It's a question that doesn't need much thought to answer. I think it would be really helpful because I think on the whole, people learn from example. You know, this is an immense inquiry, as you will know far better than I, thank goodness. And I think there will, you know, it's already clear just from today's discussion, there are an awful lot of lessons to be learned, areas of improvement. And I think by giving examples, people learn from anecdotes far more effectively than they learn from series, particularly when it's something that's outside their experience. And when it relates to real people with real stories, I think it's the way to do it. I think there isn't a very crowded training agenda, but this certainly deserves a place in it.
Dr. Cave, the same question to you, but specifically, as well as talking of a generality, within the MHRA, is that something that your organisation might benefit from as well?
Absolutely. I don't think you can ever fail to benefit from learnings of the past. So I could only agree that actually digestible key messages in a easily understood way, it would be incredibly helpful.
Can I move on then to a separate topic and begin with you, Dr. Cave, on this? The question is that we've heard much about the strengths and the weaknesses today, and this is not directed in any way at the three of you, but is there a risk that more generally there is a potential of a degree of complacency within the UK about the safety of its blood system that could spell dangers for the future? I could ask that of you, Dr. Cave.
I would like to think that we're always learning and we're always looking at how we can improve our systems. I think I've started this role about a year and a half ago now, actually not quite a year and a half ago, and I've been really encouraged at how the agency is continually looking for ways of improvement, and I think the step change that we see coming forward with the Safety Connect system, but also the learnings of COVID, the learnings of proactive pharmacovigilance, trying to anticipate events before they've happened, looking at how we can follow groups of patients who we consider most at risk, looking at how we can bring on new analytical methodologies, looking at how we can use smartphones and new techniques to reach patients better, to get those patient perspectives. We have engagement processes to understand how we can communicate better, not only with patients, but with healthcare professionals. So we're not complacent. We know that adverse drug reactions, for example, still provide a huge burden on our national healthcare systems, and we must do everything that we can to reduce them.
Thank you. Professor Neuberger, obviously you and your colleagues on SABTO could not possibly be accused of this, given that you were giving up your own time to sit on such a committee. But if you think about your experience more generally within the health service, are you concerned in any way about the possibility of complacency about the safety of the blood system within the...
I think that is in general, people who are not involved, I think those involved, like the three of us, have shown, as you say, very clearly that we're not complacent. And I hope that comes through, and anybody who's heard any of the individual stories cannot be anything other than not complacent. I think there is, as I alluded to earlier, I think there is this difficulty in relaying risk. We do talk about very safe blood, and that's true, but risk can be mitigated but not abolished, and it's getting that balance right. So I don't think one ought to over-exaggerate the risk, but equally one needs to be very much aware of the consequences of that risk, if you will. And I think getting that balance right is I think, something we could improve on, because I think I would agree that there is a degree of complacency, and that is why I think many clinicians outside the blood transfusion area really don't consider transfusion-related risk as a major issue. And I think complacency is a problem out there, and people are not aware. Again, one of the unintended consequences, I think, of the IBI is it has raised the profile of risk, but my guess is that unless we build on this, it will dissipate over the next few months and years, and that would be a shame if we allowed that to happen.
This inquiry, but the Chair's subsequent report will be an opportunity, will it, to reinforce the kinds of points that you've been making today?
It will raise the risk, but I think my concern, and no disrespect, is it will be transient. The people involved will be scarred, but I think the future generations of clinicians, of nurses, of doctors, biomedical scientists and others, it needs to be reinforced once the immediacy has gone. And I think that translation into permanence is going to be a key challenge.
Professor Bellamy, could I ask for your thoughts on this?
Very similar to Professor Neuberger's, really. As you say, if something is perceived to be safe, it's only a question of time before complacency sets in and people's attention focuses on something they don't perceive to be safe, and sometimes miss the elephant in the room. Ask any anaesthetist, what's the threat here? They will tell you, oh, the threat is I can't get the tube in and maintain this patient's oxygenation. But maybe that wasn't the threat. Maybe the threat was they were so focused on that their technician had brought the wrong unit of blood from the fridge, and they, in their rush, hadn't checked it properly. They didn't check it properly because the technician brought it. It must be the right unit of blood. Have you done your transfusion training? Yes, of course, I've done my e-learning. It's all been signed off. Did you actually check that patient's wristband against that unit of blood? No, but I checked it against the notes. Are you sure that was that patient's set of notes? So you can see how complacency does exist and how complacency does turn into errors, into SAEs and SARs. That was not entirely a hypothetical story that I told you. Unfortunately, it's the sort of scenario that we've seen many times over the years. The only mitigating factor is if it happens that purely by chance, that unit of blood might have been the right blood group, but that would just be very lucky. So do I think complacency is a big issue? Complacency, yeah, it is a big issue because, and particularly around something which has got this label on it of being safe. If blood transfusion was labelled as being potentially very safe, then that might just send out a slightly different message.
Does it tie in as well with the myth busting that we were discussing previously? The tendency to give more blood than may be necessary stems from this complacency that it's a safe product and it's better to err on the side of caution.
I think that's I think that's a very sensible observation. Yeah.
If I can turn to a slightly different area, and this is on to Sabto, to you, Professor Neuberger. The first question was about the guidance on consent that you sent to clinical journals. I think I can answer this by referring to people to paragraph 3.8 of your statement, where you set out the article that you published, and the inquiry references WITN 7001045. I won't take you to it, but people can see there, from the wider SABTO report that we did bring up, what that guidance was. The question I've been asked to put to you is, you've stressed that SABTO doesn't have executive powers. Would SABTO want executive powers, and would it help?
Be careful what you wish for, I guess. Yes, in some ways it would be very nice to have executive powers, and I would have to say a budget and an ability to enforce those executive powers. I think in terms of whether to be a review of the haemovigilance system, then that would be something, whether that would best lie with SABTO or another body, I think would need discussion. As I say, it's great luxury being an advisory body because we can give the best of, we don't have to take responsibility for our decisions. We take responsibility for our recommendations, and that's a big difference. I think it would require a different approach. In many ways, yes, I'd like to see our recommendations implemented and implemented more swiftly than sometimes happens at present. I'd like to see us being more rapid and more responsive, but that requires significant changes, resources, both human and financial. But I think it does interact with other key players, and I think there would need to be some discussion. I don't think it matters who does it. The key thing is it's done. But as I think we've alluded to, affecting healthcare professionals' practice is a long-term business. It's uphill. It shouldn't be, but I think that's the reality, unfortunately, and we need to just work at it. I haven't really answered your question.
No, I think you've taken it as far as you can. I'm going to put a similar question to you, Professor Bellamy. You say in your statement that something that you would like to see change is that some, at least the major recommendations made by SHOT, becoming mandatory. Can I ask you to expand on that and whether SHOT should have any executive powers?
Yes, so two distinct questions. I would like to see the major recommendations made mandatory because it's not that I wish to create more rules and regulations for healthcare providers, but at the moment, a proportion of trusts do adopt the recommendations, a further proportion do not. Others comply for a short period of time, and then there's progressive attrition. So making the recommendations mandatory would address that. It may not be the only way of addressing it, The downside, of course, of it is as soon as a body like SHOT, a haemovigilance organisation, is tasked with making a mandatory recommendation, that then changes the dynamic of the organisation itself, and it may impair its ability to come up with the right recommendations. So I think there is a trade-off to be had, and if we were in a position to make mandatory recommendations, I think it would be interesting to revisit that after 2 or 3 cycles of the process to see whether it had had an impact on the quality of the judgment. Certainly, I think if we were making mandatory recommendations, we would be under pressure to make certain recommendations and not certain other recommendations.
Where would that pressure come from?
It could come from a number of sources, but I suspect the hospital trusts and health boards would wish to have a voice, and they may exercise that voice centrally.
Is what is partly behind this the fact that, as it stands, SHOT is able to put forward examples of very high standards of practice, which it would like everybody to attain. If your recommendations were mandatory, the temptation would be to lower the standard that you're suggesting.
I suspect that may be the case, but I'm also concerned that we would make a recommendation that we thought was a good recommendation, and trusts more broadly may then, through whatever channel, say, well, actually, that's too expensive or that's not deliverable. Please, can you change that recommendation, or water it down or remove it? And I wouldn't want to be in that position.
You have spoken about how SHOT follows up in its survey, its annual report. Professor Neuberger, I've been asked specifically about the advice that SABTO has given on consent. Is there a mechanism by which SABTO has monitored how closely its advice has been followed?
No. Essentially, as I mentioned, it's really outside our remit.
Yes.
And we have no mechanism or authority to do that. I mean, we work with the blood services who have an interest with the transfusionists, with SHOT and so on. But this is as far out of out of our remit that we can go. We have certainly no ability to monitor it, and I think others will. The professional bodies and so on. It lies with them really to take this forward.
As we saw earlier, NICE has done some work on its
Yes.
own guidance, which overlaps quite significantly with yours.
Yeah.
A question for both Professor Bellamy and Professor Neuberger. In your discussions, you've both described having lay people involved in your systems as being invaluable. Can I ask, or the question I'm asked to put to you is why do you feel that it is invaluable? Firstly, Professor Neuberger.
Firstly, they give a lay perspective, which is always helpful. Inevitably, we do get into a bubble. There's a danger we get into groupthink, into take and receive wisdom. So to have external people providing input is important. Secondly, that they have personal experience and understand the implications of proposals that we're considering making. And for example, with the hepatitis E recommendation and the cost, it was very helpful to get their input into that. Were we making a reasonable or an unreasonable assumption? We're very fortunate in that one of our lay members was, and although he's there to represent one aspect, so say we have two, one for blood and one for organs, he's actually used to work in the safety industry, in the safety aspect of nuclear industry, and that gives us a very interesting new insight into risk-benefit. So there were additional ones, but predominantly it's there to give, if you like, not to represent the views of patients. I think that's a very different role, requiring a different process. But they give us an input into making sure we're grounded, we're sensible, we're realistic, and also an independent, if you like, extra group think. And there's always a danger that they go native, if you will, but they're strong characters, and that's part of the selection, that they hopefully won't go native and they'll continue to be independent.
On that theme, if they're sitting around a table with a group of, spare your blushes, eminent experts in the field, how easy is it for them to offer their tuppence worth?
I think it's very much my job as chairman to make sure they do have that opportunity, and I hope I succeed in that. But I do talk to them in advance of the meeting. When they have concerns about some of the papers, we'll have a discussion over the phone, usually, to clarify issues. But I think it's very much part of the chair's role to make sure that the lay people don't feel inhibited by the experts, and that they are experts too, but in a different way.
Professor Bellamy, could I ask if you have anything to add to that?
Yeah, I'd agree with all that Professor Newberger said, but also to add that the lay members on our steering group frequently, with every agenda item, come up with questions that the rest of us never thought of. And that's really useful, because first, it means we actually get to consider those issues. And second, it makes us understand how our thinking isn't necessarily aligned with what the public as a whole might see as important.
Dr. Cave, can I see if you have anything to add to that?
I would just agree how it's absolutely impossible to hear, important to hear the lived experience, because it brings a new perspective to the discussion. For us, it's incredibly valuable to have the perspective on risk communication as well, on the format of the risk any additional education materials we may be proposing, or additional risk mitigation measures, and also ultimately down the line the impact of those measures on their health outcomes or their experience of using the product down the line. So very, very valuable.
Turning to emerging risks, and this is again for you, Dr. Cave. You spoke about the response that would take place within the MHRA as well as the wider response to such an emerging risk. I'm asked to ask this, how long would a risk assessment from the MHRA take, and would any interim measures be put in place during that time?
Yeah. I hate to say it depends, but it depends on a lot of factors. So if it's a very urgent risk or a particularly serious risk, we do have the powers to suspend a product while that risk is being examined. So that remains an option if we felt it was potentially a fatal reaction or something so widespread that we couldn't have any measures to control it. So we do have those powers. We can launch a major safety review, which you alluded to earlier, which has very strict time frame around it. Other than that, it depends on the availability of the materials, the data, whether we have to do additional studies, which we commonly do to assess a risk, whether we need to ask the manufacturer to provide all of the data that they have on their product that might inform on that particular risk. And then, of course, it depends on the time it takes to draw it together. So it is very hard to give you a time frame. If it's something very small, it's quick. If it's a bigger review, it can actually take quite a substantial period of time. And obviously, if we decide to set up an expert working group on a particular issue, then that builds an extra time, but we get a completely comprehensive response. If we decide to go for consultation, that connects extra time, but we bring in that valuable lived experience and the perspective of the patient. So it really depends on the comprehensiveness of the review and the urgency of the review. But we do have powers if we feel it's a very serious risk to suspend the use of the product while we're investigating.
Can I ask, perhaps without going into detail, but have those powers been used?
I'm trying to, not in the last, not in my recent experience, but we have launched a major safety review, for example, recently, so on an anti-epileptic drug. So we are using those powers. And of course, COVID has been a big issue.
I should point out you didn't have notice of that question.
No.
And so,
No, but we've, initiated several reviews even since I've been at the MHRA.
turning to the figures, we looked at some figures from the SHOT report earlier. There are also some figures given in your statement, Dr. Cave, about the number of incidents reported to the MHRA through SABRE. Forgive me as I just try to find where those are.
I think it was about 1,000, if I remember.
Here we are. Can we have WITN 7477001, page 19, please? Paragraph 6.5. We can see there the Haemovigilance team processes around 1,000 SAE reports, and 450 SAR reports per year. The SHOT figure, and of course, different reports go to different organisations, so you wouldn't expect them to tally with one another. The figure for SHOT that was obtained from the table the total figure of reports was 3,161 from the 2021 report. The question I have for both of you is, have you seen any discernible trends in recent years as to how those figures are developing? If I could ask Dr. Cave first.
So I did ask the team to give me the last decade of experience on reports. And I can see from those numbers that there's been a gradual increase, not a step change, I think, but a gradual increase in the number of reports year on year.
Now, there are two possible causes of that, both of which may be at play. One is that there are more incidents, and one is that there is better reporting. Are you able to say which or both?
I'm
apply?
not actually able to give you that understanding over the last 10 years. I could ask the team to feed back to the inquiry their thoughts on that, if that would be helpful.
We will ask the chair and no doubt be in touch if it is.
They're not necessarily alternatives.
No, they're not. Professor Bellamy, same question to you. Any discernible trends?
In the early years, of course, the reported numbers were quite small. The last couple of years, our reported numbers have been about the same. We're not sure yet what the impact of COVID was on reporting, whether the number of events went down or simply the number of reports went down, but we managed to sustain reporting largely during COVID. In general, however, when we see numbers of reports going down, we are generally concerned that there's a problem with the reporting process rather than that things are getting miraculously safer.
What do you base that concern on? I mean, why do you assume this? Because the number of reports are going down.
And SHOT generally, our steering group tends to take a worst case scenario view, it's not that this is definitely that the number of reports are going down, but that would be the more worrying of the two scenarios. So therefore, that's the one that we are keenest to react to and explore whether or not that is the case. The other factor, there is a figure somewhere in the SHOT report, but I can't now remember the exact page, which looks at reports by specialty areas and so on within hospitals. And that has been a little bit dynamic over recent years as well. And I'm not sure if that, for example, reflects increased pressure on accident and emergency departments or on operating theatres as opposed to other areas. And I suspect that, as you pointed out, because these explanations are not mutually exclusive, one explanation may apply to some areas, whereas the other explanation applies to others.
A different theme, and looking back to when SHOT was established, did SHOT, or does SHOT, look back retrospectively at transfusion infections that took place before the establishment of SHOT in 1996?
We haven't done that. Our data on transfusion infections basically are fed to us via the UK Health Protection Agency and Professor Sue Brailsford, whom I believe you've already spoken to. So they would be the custodians of the primary data there. We only look at infections which are reported in the reporting year on which that report is based, irrespective of when that infection was transmitted. So it's entirely possible. Hepatitis C is a very good example, because in the 1990s and early 2000s, in many cases, there was very significant latency between infection and diagnosis. We could only pick those up and look at them as potentially transfusion related in the year of diagnosis and reporting.
Related to that, could SHOT make a recommendation that all patients who have received a blood transfusion be tested for hepatitis C?
In principle, it would be possible to make the recommendation. However, I'm uncertain as to the desirability of making that. Certainly for those who have received a transfusion in more recent times. There is a greater argument, because the risk of hep C transmission is greater, for those who receive transfusions further back. But if those individuals had received a hepatitis C contamination from a transfusion further back, then it is likely that that diagnosis would already have been made by now. Although it may be that Professor Neuberger is more qualified to answer this question than I am.
I will turn to him, Professor Neuberger.
I think that's an interesting question which I'd need to think a bit more thoroughly about, but I think it brings us on, intentionally or otherwise, to look back. And of course, one of the things that happen when we identify something like hepatitis B, for example, or there is a potential, is look-backs are undertaken, and the blood services have already measures in place to do that. I don't know if you want me to elaborate more on that at the moment in view of time, but I'm happy.
If you could, I am a little conscious of the time, but
yes.
I'm also conscious that this isn't an area that we have touched on so far, so that people are aware. Section 4 of your statement and the documents that relate to Section 4 deal with the occult hepatitis B virus infection look back, which you prompted and Sabto discussed, and those documents are there. But could I ask you to please elaborate a little further?
Thank you. I mean, essentially the principle of look back is when you know there's been an issue in the blood supply that has already happened, is whether you go back and test recipients of potentially infected blood. And when, for example, and this already happens, and it may be a trace back when one patient gets a potentially blood transmitted infection, then you'll go back, look at the donor, and if the donor was infected, then you'd contact the other recipients and advise them accordingly. When you have it on a big scale, and this came to our attention with a condition called occult hepatitis B, it became clear to us that the current testing of samples for hepatitis B, that looking at HBV DNA, which is the genetic element of the virus, that there was a small number of donations where the HBV levels, the amount of infected virus, was below the limit of detection using our current techniques, but the blood transfusion volume was enough to infect the patient. And this gave us concern. We looked at this, and again, Sue Brailsford and the team were key in this, and we made recommendations which were accepted and now being implemented, so that we could reduce that risk by additional testing. But it became clear that there were some patients who were at risk of having received what we call OBI, occult hepatitis B infection, and the blood services have already started, put in plans, processes to identify those patients, inform them, and offer them treatment, counselling, and advice. But it became clear that there were a number of issues which hadn't really been resolved. Different blood services had different approaches to it, slightly different. There were issues, for example, about it was very dependent on a number of external bodies, such as primary care and hospitals, who weren't often very helpful in responding. So you didn't know whether the patient was even necessarily alive, whether they're under care, what their condition was. You clearly, it may not be appropriate to contact somebody to let them know. There's also the issues, for example, of how far you test their partners. So supposing the patient has died, maybe from the cause for which they were given the blood or blood product, but should you then contact the partner? What is the ethical thing to do? How far back should you go in the testing? And along with that is, do you keep serum stored? And or plasma stored, how much do you do? How long should you keep it for? How should you keep it? Who's going to pay for that storage and its maintenance and so on? So there were a number of questions which we felt were important that hadn't been explicitly addressed. And these were not just of importance to us and to the blood services, but to the general public. And we felt that this should be a much more transparent, consultative approach rather than just a SABTO simple recommendation. I thought this was going to be a fairly simple approach, and yet another case of how wrong I was. And then along came COVID. So there's delay, and Professor Brailsford is now running a subgroup, a working group to try and produce guidelines. She hopes to have some recommendations to SABTO in the spring of of next year, and we will review those, and then once they're accepted, they will go for further discussion. As I say, this is not just a simple scientific or cost per quality. It is a much more general question. There are ethical issues, there are practical issues, there are legal issues, and it will need a wider consultation. But I hope, unless this is treading on the territory of the inquiry, we hope it will be a useful contribution to the debate and provide some helpful guidelines. Hopefully they'll never need to be used, but in practice I think that's an unlikely aspiration. So that's where we're at. But I think the look back, as I say, they're already being done, but there's still some unanswered questions which do need some discussion and thought and some clear guidance for the future.
Is this perhaps an example of the benefits of having an independent expert panel that can identify where there are these gaps and then take the initiative in trying to fill them.
Yes, I think you've got to combine the, if you like, the independent expert from those involved in the day-to-day practice, those who've been through it and know some of the weaknesses. So I think you've got to bring the two together. Those who've had experience, who've done look back, seen the weaknesses, have the questions raised, the patients who've been affected by look back, and then the independent experts who will give their own view. But as I say, I think this is a sort of issue for SABTO that is of a much wider one we'd go out to consultation on, rather than many of our other recommendations, which will go straight to ministers.
Another question for you, Professor Neuberger, which is this. Why are people who have been cleared of hepatitis C not allowed to donate blood or organs for transfusion?
It's a matter. Hepatitis C is different from hepatitis B, but we're still need to be absolutely sure that there is no risk of transmission, that the virus can lie dormant. For example, we know that some infectious agents can lie dormant for years. We know with hepatitis B, which is a DNA virus, it's a different group of viruses. But I think on the precautionary principle, again, it's best to safeguard. I mean, we'd like everybody to donate if they wish to do so, but we do have to balance the protection. And I think it's mainly on a precautionary basis that have they really cleared the virus? Would there be any element in their blood that might transmit the virus to, particularly to a susceptible individual? So I think that's why we've erred on the side of protection of the recipient rather than the rights of the individual to donate. The science perhaps is not robust, but we'd rather play safe in this case than...
A final topic from me, and I'll turn first to Professor Bellamy, partly to give Professor Neuberger a break. Monkeypox. It's been raised by a core participant, and could I ask for an overview of the approach that SHOT has taken to the effect of monkeypox on haemovigilance in this country?
So far, we haven't incorporated monkeypox into our algorithms. We haven't had any reports. If we were to receive a report, then clearly we would apply our usual processes to that. Until we receive a report, we don't know whether this is actually going to be a significant problem in terms of transfusion-transmitted infection. So again, we, unlike SABTO, we are not assessing potential future risks and coming up with policy advice for government. We are monitoring what's happening now by whatever cause, drawing conclusions about the patterns, the levels of risk actually observed, and reacting to those. So we're much more reactive than SABTO. So for that reason, I can't really answer that question to any further extent.
Professor Neuberger, the ball has been struck into your court. Could I ask your response, please?
Yes, I mean, at the moment, SABTO has not specifically considered this, but we know that this is being managed by JPAC, that they are identifying potential patients and deferring them at the present time. So we're not aware of any major issue for the blood supply that is not being safely managed as it is. So this is one area, if you like, where SABTO, with only 4 regular meetings a year and so on, is not in a position to initiate action. As I say, we do monitor it. I do check with JPAC that they have it under control. The blood services are doing again, their bit. So we do talk to each other, but only if it were to become a significant problem that wasn't being adequately managed would we become involved, I think, at the moment.
And just so that everybody is aware, JPAC is the Joint United Kingdom Blood Transfusion and Tissue Transplantation Services Professional Advisory Committee.
Yes, and yes, it's a group of variety of blood experts, microbiologists, epidemiologists, public health. They have a number of committees, including one looking at horizon scanning and so on. Again, we rely on their expertise for horizon scanning, and in their turn, they use not just the UK data, but an international collaboration. I think horizon scanning, you know, what's coming next, nobody really predicted SARS and a number of other, nobody predicted Ebola as far as I'm aware. Monkeypox, some people had predicted because of the decline in smallpox vaccination, which gives you cross protection. But again, the ones where it does help us is things like West Nile virus and dengue fever, where particularly ticks and mosquitoes and other are starting to creep across into the UK as a result of climate change, and of course tourism, people travelling to endemic regions. But those risks are being identified and managed and watched, and we have a role, and JPAC and the new and emerging infections have a role.
Dr. Cave, if I could ask the same question specifically of monkeypox of you, does MHRA have a role in that respect?
No, our role is to implement the recommendations of the BSQRs, which would rely on the committees that Professor Newberg's talked about, giving new advice to implement new testing regimens within the donor donations of blood. So that was our role. If that was a recommendation, we would then monitor its implementation.
So those are the questions from the core participants. I turn now to you.
Well, I have no further questions of my own at this stage.
I turn to those who are representing. We give all of our witnesses an opportunity at the end of the evidence to add anything else that they wish to do so. And if I could go down the table, starting with Professor Newberger.
Much to my, I don't know, surprise or horror, it's been a really helpful experience right from the witness question statements to this, to review again much more critically what we do, where the gaps are, and how we can continue to, I hope, improve what we'd function, what the problems are, and maybe some of the solutions. And I think, as I say, I think blood is safe, but it's not free of risk.
Dr. Cave, if I could turn to you, please.
Other than echoing those comments, I would also just like to offer my condolences to those affected, infected and affected by this inquiry, and I very much hope that through this really rigorous process, a similar incident could never ever occur.
Professor Bellamy.
Likewise, earlier on I mentioned how sorry I am for those both infected and affected, but the flip side is I'm extremely grateful to the inquiry for having the opportunity to discuss a little around what SHOT, MHRA and SABTO are doing, and perhaps get a steer from you on maybe where we should be going next.
Well, can I, for my part, thank you collectively for what has been at times reflective, always interesting, never, may I say, complacent. You've demonstrated that. Certainly, in elements, very enthusiastic about the work which you each have been doing in your own particular respect to protecting the blood supply. I'm not sure if I'm pleased or not that it should have been a process which has caused or seemed to be so rigorous in your view, Dr. Cave, and created horror in yours. But if it produces something which benefits all, then I shall be particularly delighted. So thank you. Tomorrow.
Tomorrow, so we have Professor Graham Foster, Professor John Dillon, Dr. Brendan Healy, Dr. Joanna McLean, and Dr. Michael Mulholland.
Tomorrow then, 10 o'clock.